So next is V7 gastric lymphoma, and it is a 57-year-old female present with symptoms of weight loss, early satiety, and occasional epigastric discomfort. She undergoes a gastroscopy, which reveals a hypertrophic nodular mucosa in her stomach. Biopsies confirm mucosal associated lymphoid tissue gastric lymphoma. Outline your management of this patient. So I would inform the patient of diagnosis and discuss her investigation results at the upper GI MDT. Staging investigations will include CT thorax, abdomen, and pelvis, endoluminal ultrasound scan to assess the depth of invasion and surrounding lymph nodes, and a bone marrow biopsy. So mucosal associated lymphoid tissue is a low-grade B-cell lymphoma and strongly associated with H. pylori infection. So H. pylori eradication is recommended with 14 days of antibiotics treatment associated with high dose of proton pump inhibitors. This will result in complete remission in majority of the early tumors, and follow-up 6-monthly endoscopy and biopsy of the area is required with overall 5-year survival to 90%. A repeat endoscopy is carried out and there is no change in the endoscopically visible lesion or on biopsy. What management would be recommended now? So again, I will discuss again on the MDT, and neoplasia may remain in 20 to 25% of the patients, and sometimes in selective cases we can offer radiotherapy or chemotherapy. This lady returns few years later with night sweats and non-specific abdo pains. Repeat endoscopy shows a large fungating tumor of the stomach. Biopsies show this to now a diffuse B-cell lymphoma. What would you recommend now? It is possible there is a transformation of gastric malt into the diffuse B-cell lymphoma. I would arrange a repeat staging with CT and PET scan. Now again, we're doing staging in the form of CT and PET-CT. Oncology opinion is advised for consideration of chemotherapy in the form of CHOP or CHOP-like regime with or without rituximab. The eradication of H. pylori is advised again. Surgery is reserved for cases which fail to respond to chemotherapy. While receiving chemotherapy, this lady arrives in the ED with severe abdominal pain, tachycardia, and hypotension. An erect chest X-ray shows infradiaphragmatic air. You proceed to order a CT that reveals a large amount of intraperitoneal air and fluid around the stomach, liver, and spleen. What are the management options here? So this lady looked like perforated stomach while on treatment for gastric lymphoma, and this can occur due to the rapid response of the lymphoma to the chemotherapy, with the tumor necrosis and lysis causing a breach in the serosal layer. Conservative management is unlikely to be an option depending on the patient's other comorbidities. She should be considered for emergency laparotomy and gastric resection with a subtotal or total gastrectomy. Complication would be significantly higher as compared to the elective patient due to the presence of intraperitoneal contamination, as well as the patient factors including possible neutropenia, decreased nutritional reserve, anastomotic leak, intra-abdominal abscess, duodenal leak, gastric general complication, respiratory, cardiac, and wound complication. The patient should be appropriately consulted preoperatively about these risks and estimated mortality and morbidity probabilities calculated. So in this scenario, they mentioned very early stage of MALT, and then advanced stage of MALT, and then in emergency perforated MALT. So these three options are there. Thank you.